This lecture will look at the care of clients that have hematological disorders. Overall, approximately 1/4 of all deaths in the United States are due to cancer. And despite advances in treatment, more than 500,000 Americans, which is more than about 1,500 per day, die from cancer every year. The most common cancer in women is breast cancer, and the most common cancer in men is prostate cancer. Lung cancer is the leading cause of cancer deaths in both men and women and causes about 29% of all cancer deaths. Cancer, as you know, occurs when the normal cells mutate into abnormal cells and then proliferate throughout the body. And it can cause many, many different types of malignant disorders. However, our lecture is just going to focus on cancers within the blood system and also within the bone marrow. So we're going to be mainly looking at leukemias and lymphoid types of disorders. When we look at the etiology of cancer, it can be from many different causes. Probably only about 5 to 10% of all cancers are actually due to hereditary or genetic component factors. Most of the types of cancers are due more to environmental causes, viruses, immunological problems, and there have been some links to some different types of psychosocial issues that have been linked to different types of cancer, being more prone to cancers, I guess is a good way to say it. Advanced age also increases cancer risk because about 3/4 of all cancers are diagnosed after the age of 55 years. So environmental factors are listed in your textbook, but those also include chemicals, tobacco, alcohol, diet, radiation, and things like that. The warning signs of cancer include the acronym CAUTION, which stands for a change in bowel and bladder habits, a sore that does not heal, unusual bleeding or discharge, thickening or a lump in the breast or elsewhere, indigestion or difficulty swallowing, an obvious change in a wart or a mole, and a nagging cough or hoarseness. Many different types of diagnostic procedures are done to diagnose cancer, and those include blood tests, stool tests, cytological examinations, radiographic and imaging tests such as chest x-ray, mammography, tomography, ultrasounds, MRIs, CT scans, endoscopies, and those types of things. Since we are going to focus on blood cancers, leukemias, and those types of things, we need to look at what the different blood cells are just as a review. I know you've had this information in pathophysiology, pathophys before, but just a reminder, the leukocytes overall are your white blood cell count, and remember about 50 to 70% of your overall WBC count is going to be from your neutrophils. These are broken down into your segs and your bands. Remember, your segs are your mature neutrophils and your bands are your immatures. Lymphocytes account for about 20 to 40% of your WBC count, and remember, neutrophils, their major function is phagocytosis. Your monocytes account for about 2 to 6%. Your eosinophils are about 1 to 4%, and remember, those are what are elevated in hypersensitivity reactions. Your basophils also are elevated in hypersensitivity reactions. Your red blood cells, also known as your erythrocytes, last, remember, about 120 days. And your platelets or thrombocytes, which help to control bleeding, are the last type of blood cell that are listed on this slide. When we break down the white blood cells, we've talked about on the previous slide some different functions of them and percentages that you see in the overall WBC content. But this is just a review of what the different types of white blood cells are and what their specific types of functions are within the body. So remember, your neutrophils are elevated with bacterial infection because that is their goal, to help fight that infection. Eosinophils are elevated with any type of an allergic reaction. Basophils are also elevated with stress or bacteria. And monocytes, remember, are your macrophages that help to ingest microorganisms. Lymphocytes typically are elevated with viral infections and do have specificity and memory. So for cancers of the blood, we would typically think to see that that patient's going to have a workup with a CBC, peripheral blood smears, bone marrow aspiration to help to diagnose which type of blood type is abnormal. Lymph node biopsies may also be done, as well as a whole body scan to look and see if that patient has had metastases or involvement in any other organs elsewhere within the body. The patient that undergoes bone marrow aspiration, it will be done to diagnose types of cells within the bone marrow itself. During this procedure, there's actually a small sample of cells that are taken from the bone marrow, and this is done to get that core tissue so that they can look and see what types of cells are actually growing in that patient's bone marrow. Typically, the procedure takes about 20 minutes. The patient is usually given some sort of a sedative with the procedure. They also are given a numbing medicine such as lidocaine at the site of the procedure. Typically, it's usually done in the posterior iliac crest. Can also be done in the sternum. It's the physician preference. And a stylet is used to aspirate that small amount of bone marrow. Patients do feel quite a bit of pressure as that needle is inserted through the bone. And once that's removed, then those biopsies are sent down to the lab for examination and that type of a thing. So pre-procedure care would be to make sure that the patient understands what's going to happen during the procedure, that a consent form is signed, that the patient has vital signs recorded, the patient's put in the correct position. Obviously, they're going to need to be supine if it's going to be done from the sternum or anterior iliac crest, and the patient will need to be prone if the patient's having the procedure done from the posterior iliac crest. This is a diagram of what this procedure would look like as the patient is having this done. Nursing interventions for the patient having a bone marrow aspiration would be to offer comfort and support. Typically, patients will have dressing applied to the puncture site for about 24 hours, and they need to be watched for infection and any signs of bleeding. And typically, patients are told that the aspiration site may ache for a couple of days after the procedure. So usually just over-the-counter medications are used for the post-procedure pain. Patients are not supposed to get the area wet for about 24 hours afterwards and to leave that pressure dressing on the site for 24 hours, and are told the signs and symptoms to look for in case of an infection. Nursing diagnoses and outcomes for bone marrow aspiration are listed here. So patients may have knowledge deficit, anxiety, pain, risk for decreased cardiac output if they would have extreme bleeding from the site, which would be very unusual, or the patient's at risk for infection. For other types of cancers, patients may also have procedures done. The lectures that we're going to look at in particular on the rest of this lecture are going to include the leukemias, different types of lymphomas, and also multiple myelomas. Leukemias, when we talk about this type of cancer, it's a proliferation of one particular blood cell type, and the defect originates in the stem cell, the myeloid or the lymphoid stem cell. And what happens is there's an unregulated proliferation of white blood cells in the bone marrow. The cause of leukemia is not really known. There are some links to genetic or viral influences on this particular type of cancer, and it's typically diagnosed and classified according to whatever stem cell is involved. And this would be determined after that patient had had a bone marrow biopsy done. There's about 35,000 new cases in the U.S. every year, and it's diagnosed 10 times more frequently in adults than children. Although we are going to talk about one particular type of leukemia, which is the acute lymphocytic leukemia, which is typically more common in children. Lymphomas are neoplasms of lymphoid tissue. These typically derive from B lymphocytes, and these are classified as Hodgkin's or non-Hodgkin's lymphomas. Multiple myeloma is a malignancy of the mature form of B lymphocytes. And with this particular one, the patient has a problem with antibody production because the patients have the issues with the B lymphocytes not functioning as they should. So this slide just breaks down, as we talked about previously, where the disorder is for the patient that has different types of leukemias or lymphomas and those types of cancers. This just shows you that all cells in the body that deal with blood and lymph tissue actually derive from the stem cells. And these stem cells produce, as you know, specific types of blood cells. The myeloid cells typically produce your erythrocytes, your leukocytes, and your platelets, whereas your lymphoid stem cells produce your B lymphs, your T lymphs, and also your plasma cells. So your B lymphocytes are from your bone marrow. So in your patho class, you may have learned about humoral immunity, and these differentiate into plasma cells, which then produce your antibodies. Your T lymphocytes are from your thymus gland, and the goal of these are to kill foreign cells. So in patho, you've probably heard this referred to as cellular immunity. These T lymphocytes actually release lymphokines that destroy tumor cells and can also cause allergic reactions and things like that. So keep this slide in mind as we start to talk about some of these different types of cancers in the next few slides. The first type of leukemia we're going to talk about is the acute myeloid leukemia. This is actually a defect in the stem cell that differentiates into the myeloid cell. This is typically found in the older adult population. The peak is after the age of 60. It is seen in certain types of genetic disorders, and it is the most common non-lymphocytic leukemia. The 5-year survival rate for this type of cancer is about 40%. Typically, the symptoms that you see with patients are going to be fever, infections, weakness, fatigue, bleeding issues, and that's just because if you think about it, the normal blood cells in the bone marrow are not being produced as they should, and you have abnormal cells taking over so that the cells that you need to have for normal function are not there for these patients. So complications for any types of leukemias include bleeding disorders and infection because they don't have normal platelet function, normal RBC function, and those types of things. So typically most leukemias are going to be treated with chemotherapy. Some leukemias also respond very well to bone marrow transplants, and we'll talk about this a little bit in more detail later in the lecture. The overall goal of any patient that has any type of leukemia, however, is to get that patient into remission. Typically, this needs to be done by putting the patient on several different chemotherapy drugs, or as we talked about earlier, by having the patient have a bone marrow transplant done. The next type of leukemia is chronic myeloid leukemia. This is a defect in the stem cell that differentiates into the myeloid cell. Overall survival rate for this particular leukemia is very poor. It's about 30% for a 5-year survival rate for this. And patients many times with this particular type of leukemia complain of enlarged abdomen. They may have a very tender spleen upon palpation, and they may have some symptoms such as just general malaise, anorexia, weight loss, those types of things. So one interesting fact is about 95% of patients with this type of cancer have what's called a Philadelphia chromosome abnormality noted on the lab work. So as we talked in an earlier slide, some types of leukemias do have a genetic link or a genetic component to the leukemias. ALL is the one that is typically thought of associated with children. It's an uncontrolled proliferation of the immature lymphoblasts from the lymphoid stem cell. The 5-year survival rate for this type of leukemia is very good. It's about 80% or higher. Typically, this is most often diagnosed between the ages of 2 to 4 years old. We see it more in boys than we do in girls. And actually, after age 15, it's a very unusual type of leukemia to see in a teenager, that type of a thing, because it's usually found in a younger population. So typically, these kids would come in from abdominal pain, which is typically from an enlarged liver or spleen. They may also have bone pain, where they complain extremities hurt. They may have headaches. They may have vomiting. Patients may have bleeding issues, infection issues, those types of things. And that usually is what brings them into their physician's office. And then when they do a WBC workup on these patients and a CBC count, that's when they start to notice that they have unusual findings, and then work them up for the type of leukemia. Chronic lymphocytic leukemia is a malignant clone of B lymphocytes. This is usually found in older adults, and the average survival rate for this type of leukemia is about 14 years. Hodgkin's disease is a pretty rare malignancy. It's a cancer of the lymph system, and typically affects a younger population of patient. Usually they're between the ages of 15 to 35. Sometimes you do get another spike for those patients that are over the age of 50. But the nice thing about Hodgkin's is about 90% or more of those patients will get a full cure from treatment and live a normal lifespan. So it's more common in men than women. And when it's usually diagnosed is the patient comes in with an enlarged lymph node, typically in the cervical or subclavicular area. And if the patient's caught early, they can a lot of times just do treatment like radiation and chemo, and get the patient treated before it is spread. If it is spread into other lymph nodes and throughout the lymph system, then the patient has a poorer prognosis than if it's caught earlier. There is a link suspected that it's an association with the Epstein-Barr virus. And like I said, typically Hodgkin's starts as a painless enlargement of one or more of the lymph nodes in the neck, and that type of a thing. If those lymph nodes get extremely enlarged, the patient may have symptoms that occur because of compression of organs by the tumor. So they may start to have an associated cough, pulmonary effusion. If the lymph nodes are enlarged in the abdominal area, they may have jaundice from hepatic involvement, those types of things. And if it gets into the whole lymph system, the patient may have splenomegaly, anemia, bone pain, and those types of things. Upon labs and lymph node biopsy, these patients are noted to have what's called a Reed-Sternberg cell on their lab workup. Non-Hodgkin's lymphoma originates from a neoplastic growth in the lymph tissue with this particular one, but when they do a biopsy on these, they do not find the Reed-Sternberg cells, so this is one thing that sets it apart from Hodgkin's. And this particular type of lymphoma tends to arise more from peripheral lymph nodes, and it tends to spread early to tissues throughout the body, whereas Hodgkin's doesn't tend to do that quite as much. So with this particular one, patients may also have recurrent fevers, night sweats, weight loss, those types of things, and typically chemo and radiation are used for treatment. And risk of infection is quite high with this type of lymphoma. Multiple myeloma is actually a malignant disease of the mature B lymphocytes, and the hallmark symptom with multiple myeloma is that the patient has bone pain. So that usually increases with movement, it decreases with rest, it involves the bone breakdown and destruction. As a matter of fact, these patients can have fractures, including spinal fractures and spinal cord compression from this type of cancer. There's really no cure for it, but a lot of times chemo and steroids are given to just help provide some relief of pain. Radiation may be also useful in strengthening the bone and relieving that bone pain. So patients that die from this particular type of cancer is usually from an overwhelming sepsis or infection. Some interventions for patients that have newly diagnosed cancer would include the things listed on this slide. Many patients may have myths that cancer is contagious, those types of things, so they would need teaching in these areas. Getting the patient hooked up with coping and support systems is important, especially if you think about the treatments these patients are going to need, where they're going to be frequently coming in for chemotherapy, radiation, those types of things. Patients that have bone marrow transplants, we're going to talk about on a later slide, but they actually may be in the hospital for up to 6 to 8 weeks after their bone marrow transplant. So there would be those types of issues. Getting the patients into community support groups is also going to be very helpful. We've talked in the previous slides some of the cancer management modalities. Those can include surgery, radiation, chemotherapy, or bone marrow transplant, depending on what the particular cancer protocol calls for. Patients undergoing surgery, that's probably the oldest and most widely used option for cancers, and it's really going to depend on what type of cancer the patient has, where it has spread, where it has metastasized to, and that type of a thing. Radiation is typically used for patients that may be used for external or internal use depending on where that patient's cancer is. And it will lead to cellular damage and cell death of the cancer tissue. Chemotherapy is very commonly used for all of the leukemias that we talked about earlier, and it typically will cause cell death because it interrupts cell growth and replication during the cell cycle. There are many, many different classifications of chemotherapy drugs, and refer to your book to look at some of those different ones. And as you all know, there are many, many side effects also from chemo drugs. Typically, patients will be put on a regimen of multiple chemo drugs, and these can cause some nasty side effects that we're going to talk about in some later slides. Bone marrow transplants may be used in certain types of cancers, particularly in some of the leukemias such as ALL and CLL. And a lot of times it's used in conjunction with chemotherapy and radiation. And we're going to talk about some classifications of bone marrow transplants in a later slide. So overall, the purpose of chemotherapy is to interrupt cellular growth. It's a cytotoxic kind of a medication. It can actually cause cures of some cancers. The goal is to kill the tumor cells. Unfortunately, the chemotherapy not only affects the tumor cells, which are fast-growing cells, but it also affects any fast-growing cells within the body. So if you think of your hair cells, your GI cells, those types of things, your skin cells, those are fast-growing cells, and that's why sometimes we see all the side effects from the chemotherapy, such as hair loss, stomatitis, GI upset, and all those types of things. Chemotherapy may at times be used to decrease the size of a tumor and to relieve the symptoms that the patient has from pressure of the tumor on internal organs or different areas and those types of things. Every different types of cancer will have a protocol for it, and that will dictate what types of chemotherapy are going to be used to give the best results for that particular type of cancer. So you can read about further information on this topic in your textbook. Side effects of chemotherapy we've touched on already. They can affect any part of the GI tract because those are also fastly dividing cells, or I should say quickly dividing cells. So nausea, vomiting, stomatitis in the mouth, taste alterations, diarrhea, all of those are very common side effects of chemotherapy. We typically will give medications, antiemetics such as Zofran before chemotherapy to help with all the vomiting and emesis and nausea that the patient commonly has with chemotherapy types of drugs. Chemo can also cause skin toxicities, which can include rashes, different types of skin breakdown, alopecias, and all those different types of things. Remember that they can also cause hematological toxicity, which can result in life-threatening anemias, infection, bleeding, and also chemo can be very hard on many of the vital organs, such as the kidneys, the lungs, the heart, and it can cause sensory and perceptual alterations and neurotoxicities and those types of things. So patients are monitored very, very closely when they're on chemotherapy, with lots of labs to look at the effects that the chemo is having on all the vital organs, and to look at what it's doing to actually all the patient's blood counts. Radiation therapy is another type of treatment method for patients with cancers, and it's the treatment of choice for certain types of tumors and cancers. Radiation can reduce the size of a tumor, decrease pain, relieve obstruction, and lymph nodes and adjacent tissues may require radiation if that patient has some metastases to different areas. Radiation can actually be external or internal, and depending on that will depend on the types of symptoms that that patient has. Radiation, because it is using such high doses of gamma or X-rays, can cause skin blanching, erythema, sloughing of the skin, bleeding of the skin, ulcerations of mucous membranes, nausea, vomiting, diarrhea, all sorts of things. So we'll talk about those on a later slide. These are side effects of nursing or radiation therapy and nursing interventions. We've touched on a few of these already, but you can read through those and see the different effects that radiation can have on the body and some different interventions that can be used for these different types of effects. The patient during external radiation needs to make sure that they're using good skin care, mouth care, and infection prevention measures. So some of those interventions are listed for you in the speaker notes. So I'll let you go ahead and read through those on your speaker notes. For the patient undergoing internal radiation therapy, remember that when you're talking of radiation, exposure deals with time, distance, and shielding. So nurses and caregivers need to make sure that they are monitoring the total time spent with that patient and minimizing the distance from the patient as much as possible. Nurses that work on a oncology type of unit will actually wear a special badge that can measure the amount of radiation that that nurse is being exposed to on a daily basis, to make sure that that nurse is not subject to having a bad effect in those types of things. So patients typically are placed in special rooms when they have internal radiation therapy treatment going on. Caregivers should use special lead shields if they're going to be spending a lot of time with that patient. They wear dosimeter badges to measure the amount of radiation that they're exposed to. And nurses should not be pregnant if they're going to be taking care of patients with internal radiation therapy. And also the visitors should be limited for these patients. No kids under 16 should be visitors, and visitors should keep that distance of about 6 feet away from the patient. And anytime the caregiver is handling body fluids, they need to make sure that they're wearing gloves, safety precautions, and everything is labeled as radioactive from that patient. Patients undergoing bone marrow transplant, these patients may either receive it from another donor. That could be a sibling, that could be a random donor, someone who closely matches with antigens. Prior to receiving the bone marrow transplant, these patients are given very, very high doses of chemotherapy and many times also total body radiation in order to destroy all of the abnormal leukemic cells that are in the bone marrow. The donor's bone marrow is then aspirated and infused through the patient through a central venous line. And then the bone marrow cells actually will migrate to the bone marrow in the patient. Patients undergoing BMT are at high risk for overwhelming sepsis, bleeding issues, and those types of things. Patients that have their own bone marrow reinfused to them Typically, this bone marrow would be harvested when the patient's in remission from their cancer. It's then frozen and stored until the patient would need it. And then once again, if the patient does have a relapse, the patient's given very, very high doses of chemo and radiation to destroy their immune system, and then their own bone marrow is reinfused back into them. So patients are very critically ill who undergo this procedure. They're typically in the hospital for about 8 weeks or so, and they have a high mortality rate because of risks of infection and bleeding complications. Nursing management for bone marrow transplant would include pre-transplant evaluation, post-transplant issues, and isolation precautions that these patients would be on. Many times post-isolation, they will remain immunocompromised for possibly up to a year, so they need to watch exposure to crowds. They may be put on broad-spectrum prophylactic antibiotics. They need to be on thrombocytopenic precautions and be watching for any types of bleeding issues that they have, and watching for bone marrow failure and the issues of graft versus host disease, which we're going to talk about in a later slide. I guess we're going to talk about it right now. This graft versus host disease occurs actually in about 60% of patients that have a bone marrow transplant from a donor, and it can cause many, many types of side effects. Typically, the patient will have skin rashes. It can actually lead to sloughing of the skin, diarrhea, GI bleeding, and liver damage. What happens in graft versus host disease is that the immune cells of the donated bone marrow identify the patient who's receiving the bone marrow tissue as foreign, and the T lymphs in the donated marrow actually then attack the patient's liver, skin, and GI tract. So patients can have many different side effects from this, and graft versus host disease can actually occur within days or weeks after a transplant, and in that case it's called acute graft versus host disease, and also this can happen up to months later, and then it's known as chronic graft versus host disease. Typically, it's treated with antibiotics, steroids, and also immunosuppressant drugs. So 25% of patients also will have what's called vaso-occlusive disease of the liver from graft versus host disease, and the patients will noted to be jaundiced and have elevated liver function tests due to the graft versus host problem. These would be some appropriate nursing diagnoses for patients that are undergoing bone marrow transplants. So altered nutrition, tissue perfusion, risk for infection, anxiety, and knowledge deficit, among others, would be listed. Here's a quick little quiz for you, so you can look through that to look at bone marrow transplantation and to look at the different definitions that are used with BMT. And overall, when we look at any types of patients that have cancers that would be classified as leukemias and lymphomas, and in part of nursing assessment, weakness and fatigue are going to be very common with these patients due to anemia factors, thrombocytopenia, and all of those types of things. They're at high risk for infection due to low white blood cell counts. So looking for subtle signs of infection in the skin, mucous membranes, respiratory tract, gastrourinary, gastrointestinal, neurological tracts is all important. So these patients have very frequent lab tests done to assess for bleeding issues. Another issue for patients with leukemias and lymphomas is nutrition. We talked about the issues of stomatitis with patients undergoing chemotherapy and certain types of radiation, so mouth care is imperative. Many patients are given special magic mouthwashes that have analgesic effects. They have some lidocaine in them that they will swish around in their mouth that helps if they have stomatitis and those types of things. And we talked earlier, chemo can cause lots of nausea and vomiting. So patients are given antiemetics such as Zofran and different things. And supplemental feedings and daily weights and I's and O's, of course, are all very important in these patients. Patients with these types of cancers also have recurrent fevers, stomatitis, and we talked about the issues of bone pain in that patient with multiple myeloma. So assessing pain in these patients and giving pain medications is another important component of their care. We've touched on fatigue, so balance, activity, and rest, and physical therapy may also be involved in their care. Because of the nutritional issues and altered electrolyte imbalances due to the chemo drugs and those types of things, these patients are on strict I's and O's, daily weights, and also because many of the chemo drugs can cause kidney damage, we keep a close eye on their BUN and creatinine levels and those types of things. Some of the chemo drugs can be cardiotoxic, so we will look for signs of fluid overload, signs of CHF, and those types of things. Because they're at risk for bleeding precautions, we avoid drugs that are going to have the patients increase their PTT and PT, so aspirin and Coumadin, those types of drugs are of course going to be avoided. IM injections are going to be avoided due to the low platelet counts. Sometimes patients need to have indwelling catheters, but if it can be avoided, we try to avoid that because it's just another thing that can cause trauma and infection to that patient. So no rectal temps or meds, trying to use small IV catheters. Typically, these patients that are undergoing chemo will have some sort of like a central line, omega port, PICC line, or those types of lines in, or perhaps like a Hickman line to give their chemotherapy drugs through and also to be able to draw their labs off of. Patients need to use soft toothbrushes and safety precautions for bleeding in the mouth area. Because they're at high risk for infection due to their low white blood cell counts, anybody entering the room needs to use good hand washing. Some patients are put in reverse isolation. If their absolute neutrophil count goes low, patients are put in reverse isolation where anybody coming in to take care of them would need to have on a mask, a gown, gloves, and those types of things so that we don't give them any infectious things that we may have or that we may be carrying with us. They should really only have healthy people as their caregivers so that we don't contaminate them with any of the germs that we may be harboring. They're put in private rooms, no fresh fruit or flowers due to the risk of infection. Watch their invasive lines for signs of infection, good body hygiene, and temps every 4 hours along with other vital signs. Patients undergoing chemo, bone marrow transplants that are on oncology floors have a lot of different management interventions that are needed for them. They're frequently getting platelets, they're getting red blood cell infusions, perhaps fresh frozen plasma, all those types of things. So patients need to be monitored for complications from infusions from all these different types of blood products. There's a great care plan in your book, so make sure that you take a look at that, the client that has cancer. Anxiety and grief are going to be issues for the client as well as the family. We try to get them hooked up into support groups and just changes within the roles within the family and lifestyle changes are very stressful issues for patients as well as financial issues, loss of sense of power, loss of control, all these types of issues. So getting them some counseling many times is very helpful also. These would be some good nursing interventions for patients receiving cancer treatments: anxiety and fear, self-concept issues, altered sexuality, profound loss and helplessness, isolation, and family stress. For those patients that are put into hospice care, perhaps within the home or within a hospice, inpatient facility. These patients typically are put into hospice when they're thought to have 6 months or less to live. That's something that's usually decided between the family and the physician, the oncologist, and those types of things. Once the patient is put into hospice, it should be for comfort care only. The patient will not be getting aggressive chemotherapy or radiation or bone marrow transplant, those types of things anymore once they are put into hospice care. So hospice is a comprehensive type of a treatment modality that gives psychological, physical, and spiritual support for the family. And they will actually give counseling services for up to a year after the patient has died to the family. So for bereavement support and those types of things. Community resources that we have locally include the Victory Center, which also has many complementary types of therapies that are available, alternative medicine types of things for patients with cancer. The American Cancer Society, hospice, as we've talked about, we actually have excellent hospice affiliations locally and many different support groups available for our patients that have cancer.